an honor to introduce our next speaker, who's also a co-chair. Dr. Peter Rhee is the Chief of Acute Care Surgery and Medical Director at the Marcus Trauma Center at Grady Memorial Hospital in Atlanta. Dr. Rhee has a long history. He was in the Navy. He was the surgeon who managed Gabby Giffords in Tucson. He has an incredible volume of papers written, most of which center around the fact that crystalloid is bad. He's got over 290 peer-reviewed publications, 20 book chapters. He's also written a book. He is a very highly sought-after speaker, and we are honored that he's chosen to work with us today. Dr. Rhee retired as a U.S. Navy captain after 24 years on active duty, and basically served almost throughout the entire world. I will, with that, have him come talk to us about what are we talking about today? All right, Dr. Peter Rhee.
Thank you, Dave, for the honor and privilege of coming here today and talking to an international audience, and thanks to the people who've come here to also listen. So, what am I going to talk about today? Talk about Coca-Cola, which was invented in Atlanta, Georgia, and that's where I work now. But I'm going to talk about thoracic trauma, emerging therapies. So this is just a little alternative ways of doing things. And is there anything that we can learn about thoracic trauma? Isn't that a dead area? Well, there's some things I think if we open our eyes that we might be able to take a look at. And if you open your eyes, you might actually see the light. So this is not going to be a rib fixation talk, because I'm confused about rib fixations and I don't know what the indications are and when to do it. But I'll talk to you about some of the other areas here, 4 of them: tension pneumothorax, smaller chest tubes, retransfusion of whole blood, and then sternal fixation. So I'm not going to go into the physiology of tension pneumothorax, but I'd say that if you get enough pressure in the chest, it will actually push on the heart and you can die. But you can have a pneumothorax and a big pneumothorax and survive that. So I make that a point because what we teach on how to treat tension pneumothorax is a concept that's a great concept. You decompress that side of the chest that's got pressure built up in it and save a life. In Vietnam War, we found that 4% of the people who died probably with a tension pneumothorax, not necessarily from a tension pneumothorax. So when we teach this concept and the paramedics decompress the needle, that's where I have an issue. This lady was shot in the left chest, and they put a glove on the end of that needle, and it's wide open. Okay, so what the problem that I have is that the indications are fairly well written about and taught, but that's not what's practiced by the paramedics. And these things don't work because they don't get into the chest. And then once they get into the chest, when you pull out the needle, it kinks the catheters. And if they don't have a tension pneumothorax or they don't have a pneumothorax, they will usually stab the lung, as you know. And for the ED physicians who teaches the paramedics, to them, the saving of 1 life from a tension pneumothorax is worth them creating 20 pneumothoraces. But us, on the other hand, when we take care of these patients that have been needled, a large percentage of these people need to be decompressed with a chest tube. So theoretically, it's a great idea. It fails half of the time and probably does more harm than good when we push this idea of needle decompression out into the field. The group in USC and Los Angeles have really been pushing to put it in where you normally put in a chest tube on the side and not on the anterior surface of it. But either way, I think it requires a lot of training, not necessarily in the performance of the procedure, but on when to do it and when not to do it. So one of the ways we thought that would make it easier, because I was so tired of our patients getting a pneumothorax from the potential decompression of a tension pneumothorax, that we tested a Verus needle. As you see during the insertion, the red indicator tells you whether the needle is exposed. Again, it goes down and shows that when the needle has been exposed, meaning that it's now in the chest. This is a picture of inside the chest. You can see the Verus needle with a blunt tip protecting it from the sharp edge. And the lung here is now reinflating on its own, treating the tension pneumothorax. So this device is being manufactured right now, and the military is taking a look at this to see if it's usable. There's a lot of things we can do to make this device better. The prototypes are being made, but it can have one-way valves in it. It has ability to put lure locks onto it, and you can have visual indicators and so on like that. But it's just at least to drive home the point that we can do better than just putting a sharp needle into the chest with an IV catheter. You can even put guide wires through this in order to put chest tubes in later on. Another area that we would like to see some improvement technologically is this idea of the Plurivac. And this entire system, just to remind you, was designed to minimize the suction in the thoracic cavity as much as possible. And you can get up to 40 centimeters of water suction, but that's about what it takes to suck some Coca-Cola up through a straw. It's minimal amount of suction. And having a device that can have a high amount of suction that can be regulated is something that we would like. But we were able to publish on this study saying that you can just build simple hand pumps for use in the military, for your use in the field. And this one happens to be by a company named Bard or Navarra Bag, and you can hook it up to these types of devices. So that was the first topic. Second thing I'm going to talk about is pigtails for hemo and pneumothoraces. We know that chest tubes are life-saving, but also very painful, and we can have some atelectasis because those tubes coming out of the chest is painful. And if you have ever met a doctor who's had a chest tube placed into them, they will attest to you that's probably the most painful procedure that they ever went through. So the question that we had, and we've been studying this for about 20 years now, is bigger always better? And as we know, many trauma directors will say that they never put in anything less than a 40 French chest tube. And if there's a lot of blood coming up, he'll put in a second chest tube. And actually, there are some cities that have a guideline that if you have 400 cc's that come out, that you put in a second chest tube. And if you don't see the diaphragm, of course, they get another second chest tube. So I'm going to show you a movie. It's rated P for painful.
When you're going through the muscle and when you finally enter into the hemithorax. Sure.
They gave him 100, but you can give him some more, yeah. Give him some more.
They give him Stretch. It's unlikely that if you're...
Are you not in yet? Hey, where is local some more?
Okay, this can go on for a long time, and I'll stop it there, because I think we hate to admit it, but we've been in that situation, okay? We've all been there. Not all of the chest tubes are like that, but we've been there. So, we started looking at smaller tubes, comparing 28 French versus 36. This is in Los Angeles County, and basically we showed that it does not matter for blood. And I'm not going to start to think that this is my idea. It was a collective idea, but there are catheters which is made by Cook Company. I don't have any financial ties to these equipment that I'm showing here, but that little device is obviously much more painful, but is it effective? I think right now we are starting to accept that it's a useful alternative for pneumothorax. It comes with a kit. It makes sense. There's no reason not to. We started to publish our experience on this and showed that, yes, you can put these pigtails in all sorts of places and they get complications, but you do that with chest tubes as well. This is one where they put it in the anterior chest and it went into the heart. We just pulled the tube out and the patient did fine. And we did disclose that we did that to him. But here's also another picture of a chest tube in the liver, and we've seen pictures of chest tubes and any devices that we can stick into the bodies in every single place that we can think of. So it's the same learning pattern that you're going to end up going through. But when we started doing this for pneumothorax, we found that the blood comes out of this just fine. So we wanted to see if the hemothorax can be treated with these small little pigtail type of catheters. Now, I'm going to give credit to George Velmahos, a good friend of mine who's at Mass General and Harvard in Boston. And he says clot doesn't come out of any size hole. and blood comes out of any size hole. For those who've done emergency thoracotomies, you'll always pull the clot out. So that big jello clot that you saw doesn't come out of any chest tube. Okay, that you probably have to go in and do a VATS on a few days later on. So there are papers showing that the flow is dependent upon the size of the catheter, and we know that. And this group in Sacramento did show that a bigger tube drains faster initially, but in the overall, it makes very little difference in time. So if you have a situation where you need to have blood evacuated in a matter of a minute or two, probably still go with a chest tube and a large bore. But if you do have that chance to have a few minutes for it to catch up, then small bores will be just as effective. Now, in this patient population here, this was done by interventional radiologists who showed that in trauma patients, you can relieve pneumothoraces, but this was done in a delayed fashion, not acute patients. So our series of papers that we published in the Journal of Trauma show that for both hemothorax and pneumothorax, that the small bore chest tubes seem to work just fine. And if you look at the output from the pigtails, which are a PC, versus CT, which is chest tube, the volumes are equivalent, and the failure rate is about somewhat equivalent as well. The VATS rate was also equivalent between those patients who got a small bore tube versus a large bore tube. And comparing again the studies done by Dr. Kulvatanyu versus Dr. Naba, the amount of blood that comes out of these little tubes are just impressive. So we finally concluded with a prospective study, and then just this month we also published our 7-year experience with these pigtails, and of course they hurt a lot less, and the failure rates are similar. We like to use the Wayne pneumothorax catheter kit by Cook Company. We have no financial relationship, but everything comes in the kit as you see, including the prep and the drape. Makes it fairly easy to use. It comes with a straightener that you put inside the pigtail in order to get it into the chest, and you place that first. I like to put that in the guide wire along with the dilator onto the chest and the scalpel. I use the lidocaine. An easy trick is to just aspirate straight from the bottle. It makes it quick. Then a small 25 gauge needle to put the anesthesia onto the skin and into the chest. Obviously this patient is intubated and it's not going to feel, but having local anesthesia is always good. I aspirate the air just as a seeker needle to find out where and length of the spaces. Then I anesthetize, and then you will use the larger and bigger needle that comes with the kit. And again, aspirating, and I'd like to have lidocaine, a little bit of lidocaine in the syringe so it shows that you're in the right space. Then go ahead and give the rest of the lidocaine to the body if you want, followed by the insertion of the guide wire, which is also fairly easy to do. You do not need to put the entire guide wire into the chest. And on awake patients, they will sometimes feel the uncomfortable sensation from the guide wire. Next is the dilator, which goes over the guide wire. This is a very simple cylinder technique. Use a scalpel to make the skin incision. Just stab it all the way down to the depth of the 11 blade. And then as I insert this dilator, you want to be spitting it if it makes it easier. And then I dilate the entry several times to make sure that the wire is still easily flowable through the catheter. And then over the wire comes the thoracostomy pigtail tube with the straightener inside of it. I like to play with the wire to make sure that it's not crossing its path. Now in this case, I'm just showing that the patient had a tension pneumothorax by using a little bit of lidocaine that was in the syringe. The patient was in positive pressure ventilation and got a tension pneumothorax that we are relieving. And you can see that this is all done fairly quickly without too much of a time waste. And the patient will really appreciate this methodology at the end because the pain associated with this is so much less. This hooks up to a normal chest tube setup as you would anywhere else. And it comes with all of these adapters as well. Then it comes with a suture kit as well. And I like to just wrap it around the tube for security so it attaches to the skin. One of the things I will show you that is I like to put in an air knot, and that way when I tie it to the catheter at a distant location, it causes a bowing so it doesn't lay flat and get kinked. Put a tegaderm or dressing on top of it and put an apron around the tube. That way it is secured and will not come out of the chest accidentally being pulled. So it sounds simple, and it is. And again, we don't have any financial agreement with Cook, although there should be. I think they should pay me for that video. I'm just kidding. So size does matter, and keep that in mind, that unclotted blood will drain out of these little tubes. Remember, when we give blood transfusions to pediatric patients, we give them through 23-gauge IVs, right? Unclotted blood will flow through the smallest of tubes. Clotted blood will not flow through any tube. And that's why we go after these early nowadays. In 3 days, we'll perform a VATS if there's a retained clot. So, interestingly, it was a long-haul experience for me trying to get people to use this, but now I see it actually occurring in a large number of hospitals, and people are starting to use it for at least for pneumothorax, and I'm convinced that over time they'll see that these patients also get their blood drained out of it. And I'd say right now we use chest tubes for emergent scenarios and situations. And if I don't think I can get that needle into the airspace or the blood space, then I would prefer a finger guiding it and putting in the chest tube. But when I do put in the chest tube, I will make a big incision so I can try to have my finger in the area that I want the chest tube to be placed. I don't just poke my finger in and pull it out and hope that the chest tube goes in blindly. Next thing here I'm going to talk about is the transfusion of autologous blood. So when we did this, what we found was that when we transfuse whole blood back to the patient that comes out of the chest tube, is whole blood, and there's really no reason not to give it back to the patient. As long as you filter the blood, what we were able to show is that the red cells transfusion requirements are lower because you're actually using their whole blood and not giving refrigerated blood transfusions back. And the main reason we did this and looked at the human results was because the ex vivo or laboratory bench work type of experiments, looking at the idea of giving whole blood that came out of the chest, the shed blood, there was a lot of concern about causing coagulopathy. And what we showed was that it was insignificant. And the complication rate between autologous transfusion versus pack cells was also not different. Now, what we normally do with blood when it comes out of the chest is we throw it away. So there are companies that make these types of devices. This isn't the only one, but what we were doing was recommending that you put citrate into the collection device in order to keep the blood from clotting, and that as long as you filter it, you'll be fine. Now, there's a lot of countries that actually will wring out their laparotomy sponges and give that blood back as long as they filter it. So you will get some plasma, which is good for the body, as Dr. Holcomb talked about, but also giving the precious red cells back as well. And there's a variety of ways that you can get that in, including some of the things that you see here.
And I want to shake. Holly, just watch. And just click it like a dolphin. And then if you want it to go faster, you keep pushing it.
So these little devices which are made to take the blood out of the chamber and be able to give it back to the patient is very useful. So here's a guy who got shot in the back, and the other hole is above his clavicle. So I'm thinking, all right, I think maybe he's got his subclavian vessels, and that's an interesting case. But he was stable, so we ended up scanning him, and we found out his subclavian artery and vein were normal and they were intact. So we took this patient and we just basically put in a pigtail catheter in him. And another case came at the same time. I was operating on that patient, and the resident comes about an hour into the surgery and says, remember that patient we put a pigtail catheter in? I said, yes. He goes, well, I went by to check on him, and he has 1.5 liters of blood in his chest tube container. And I said, well, how's he doing? And he says, he's doing pretty good. So I said, well, come back in 15 minutes and tell me how he's doing. So he comes back in 15 minutes, says he's still doing great. I said, well, how much is in the chest tube container? He says, 2 liters. So I say, okay, well, bring him into surgery, get him ready and bring him in. I'll scrub out of this case and do that case. So I go and see the patient later on. How you feeling? Tight? Okay, how's your shoulder clavicle feel there?
Yeah, it's kind of sore.
And then how's that tube over there feel?
Sore.
Yeah, you breathing all right? Okay. So his pressures are all normal and everything's fine. And the reason why he was doing so well was because the nurse kept giving his blood back to him. And overall, during the whole thing, he ended up with 3 liters of blood loss. And I think we don't want to use that as a teaching case. Most of us would say, you know, after a certain amount, you should go in there and see if he's got surgical bleeding. But this is just an example of both the fact that, 1, these little tubes can drain a lot of blood. 2, that if you give the blood back, it's probably good for the patient. Finally, I'll just touch on one last thing. This is another area that I've changed my practice in the last decade, and that's on thoracic trauma. So we see this commonly all the time, right? All the time. So I just started at Grady last year, and they still hide these patients from me because they know I like to fix these sternums. So why do you fix these sternums and when do you fix them? That's the question, the indications for doing this. Well, why do we fix femur fractures? I mean, I think we know why we fix them, right? Because you can tie an umbrella to the leg and leave it there for 6 weeks and they will heal just fine. And there's a lot of ways to cast externally what we do with these bones. But we have come a long ways and we can fix this internally. We know these rods are very useful. It hurts the first couple of days after the orthopedic surgeon fixes your femur, but you can stand on that leg and it doesn't hurt for 6 weeks. So sternal fixation is something that I've been trying and been doing for a while now. And if you look at why surgeons will fix these and why they will not, most of them will do it for chronic type of events like non-unions or sternal deformities and so on, but they won't do it acutely. Okay, one more time. Can you roll towards me? No? Too much?
Hurts.
Too much pain? So he can't get out of bed. Right here. Ow. Here. Right there. Not so bad. Right there.
Right there.
Right there. Okay, so I marked that exact spot. So you have to be able to find that spot. So this is the kind of patient where the residents would say, well, you know, it's not displaced. But I go, but he can't get out of bed because he's got a broken bone. And, you know, you wouldn't do a sternotomy on a guy and not put the bone back together, right? So why wouldn't you fix this bone? And if they can get out of bed, I don't fix the bone. But if they can't get out of bed, I think it'll help them with their pulmonary function as well. There's a lot of stuff that's out there. I used to use the longer plates, but now I'm using these tiny little star-shaped plates and find that that's more than adequate for their mobility. He's got a broken back. Where did we do your surgery? This is post-op day 1. And it's not that bad right now?
No. Can you touch it?
One more time. Sit down and stand up.
Retake.
Okay. Take 2.
Okay, take 2. 1, 2, 3, go now.
Okay.
There you go.
Okay.
There you go.
Okay.
There you go.
So this is the classic case where, you know, I think a lot of the people that I see with seatbelt signs, 60-year-old female lady, and they look fine, but their eyebrows are perched and stuck to the top of their forehead, and they can't move out of bed. Those are the type of patients I find are the most responsive from this type of surgery.
Where's it hurt on your chest?
You know, when you push on my chest and things like that,
So this gentleman came to me, and he went through 4 different cardiothoracic surgeons, and no one would fix his sternum. And they told him that they couldn't fix their sternum because it was laying so close to the heart, and they were worried about injuring the heart. So he moved to Arizona to go golfing, but couldn't go golfing because of his fractured sternum. So one plate later, and he's golfing, and I went golfing with him. So again, I do it for pain. So the indications that I do it is actually for pain. I know we're taught never operate on pain, you'll get more pain. But these patients seem to be do very well. I also do it for non-union, but that's much more of a rare situation. And we need some research to do the long-term follow-ups on this, but I would say there's something else to just think about when you have these patients. And that's the end of the tunnel for me, and that's the light. So thank you very much.